And then I am going to share screen. All right, now I should be able to see the administering medication safety. And basically in your MA book, and if for some reason y'all can't see anything, or if you have any questions, please make sure you unmute yourself and say, Mrs. Scalf, or hey lady. When we start talking about administering medications, yesterday I was really pushing the rights, the right patient, right dose, right route, right. And honestly, when I'm telling you that we do this, it truly is something that I want you to always think about. Even, if you've been doing it for 35 years, I want you every time you pick up a med and to think about those. Think about the rights of the medication because safety is utmost and first. Okay? And we talked about this yesterday, how we review the order and make sure the order is correct. And then this basically what this does here is in your textbook, you can go back and you can look, and it talks about the actual procedures. If some of y'all want the step-by-step procedures, and normally I tell you these things, just read them. This is one of the times that I would tell you it wouldn't be a bad idea to take notes and actually jot down these steps because when you write something, it burns it into your long-term memory. So I suggest that. Take a look, go through. Um, And then at the very end of each one of these procedures in your book, it is going to give you um, a charting example. So this is saying on Valentine's Day, 2/14 of whatever year, 1 p.m., ASA, that's aspirin, 500 milligrams. Y'all don't know this. We haven't done pharmacology, but PO is by mouth. After, and you could have said Q, 30 minutes. No adverse reactions were noted. Verbal and written instructions regarding aspirin. Patient verbalized understanding. And then the MAs, initials. And with charting, we want to keep it very brief, very simple, but exactly what was done. So this is telling you that on this date at this time, she gave the patient aspirin 500 milligrams by mouth. And she waited 30 minutes to see if there was a reaction. None were noted. And then she gave the patient instructions and information about aspirin and and made sure that the patient understood the instructions about it. And so that's how all notes should be. They should be very clear, very precise. This also is the next procedural step, and it's just basically going over sublingual and buccal. And like I said, go through your book. If nothing, at least read the step-by-step order, because that's going to help. But if you really want to ingrain it, write it out, and you can summarize it. You don't have to write exact sentences and stuff. And then charting examples. On 2/14, the year, 9 a.m., nitroglycerin tab, 1 gram, that's 1/100, subling, that was given sublingually. So she gave 1 gram of nitroglycerin under the tongue. Patient P60, patient verbalizes understanding of follow-up instructions and uh, their understanding. This P60 is the patient's pulse. and after nitro or something like that. Because when we take pharmacology, we learn nitroglycerin is used for like what they call pectoral angina, and sometimes it can be chest pain. And one of the effects that it has is it actually should have a blood pressure and a pulse because it can decrease both. Um, so I would have done a full set of vitals and documented that there, and then made sure that the patient understood, like she did, and then put uh, their initials and signature, or however the doctor has you do it. And then inhaled medication, we talked about, it's the quickest, fastest way to get something for our lungs, right? And a lot of times, and I know we've talked respiratory, so y'all are aware of how the bronchioles can constrict, and you're aware of how important asthma is in an asthmatic patient, and using a metered dose inhaler or a nebulizer can assist that. And this goes through, and there are hundreds of different machines, but they all basically are going to do the same thing. Some of them are just room air, and that is mixed with a watery solution and the medication, and it's delivered. Some of them are used through oxygen. Some of them, I've seen these little tiny portable ones, and it's just, they basically just dump the medicine in there, and it has a little machine, and it causes it to vaporize, and they can breathe it directly in. So there's a bunch of different ones, but all of them are basically given the same effect, allowing that medication to become a vapor so that it's easily breathed in. And topical is anything that you're going to apply, we think to our skin, right? To something that's going to be absorbed. Now, eye drops, ear drops, nose, eye ointment, vaginal cream, and rectal and suppositories and so forth like that. All of these medications are being directly administered or delivered via mucous membrane. And because you think about the inside of the eye, under the tongue, right, vaginally, as a mucosal membrane. And so when you do give something like that, it's going to be a quicker, faster route. Now, the only exception to that would be topical, as in the skin. That is going to be slower because it has the layers of the skin that it has to go through. One of the really important things, and I can tell you I've heard funny stories, whenever you administer any of these medications, you always make sure that you have gloves on. Do not touch the medication with your bare hands, because some of them can actually cause effects on you if you're touching the medication. All right. When administering an ointment, especially like, let's say, a child with pink eye, if the area is dirty or it's crusted, you would need to take some type of gauze and sterile solution and probably clean it up and loosen the area first. And if anything is blocking your pathway, a lot of times you'll do that. I know we just had breakfast, but rectal suppositories, especially in older people, sometimes they'll be they'll have like what's called extra. It's basically like a stuck kind of turd, and it does have to be I've seen doctors have to remove that, or where there was one right up inside the rectum, they've removed that before they put in an anal suppository. So fun, exciting. That's not, fortunately, the doctor would be doing something like that, but just be prepared that does happen. Or maybe I was just really unlucky and saw it have to happen. When we give anyone um, on a wound or an area that has been open, you always want to make sure we clean that area thoroughly first. When we apply the ointment, some doctors will have you cover the area. It depends on the type of wound or the type of ointment or whatever we're using, Uh, and then other doctors are going to tell you, no, we're going to uh, go ahead and just let it keep air open and heal naturally. But anytime you apply more, you express to the patient too. You use a sterile gauze, sterile saline or something, and clean it and wipe away the old ointment and any kind of debris before the air, and make sure the area is clean before you apply new. Um, this is talking about the gauze and the wipe away. And these are different things. These are all topical medicines. Are they over the counter? Yeah. This is like you go out, you're in the sun for too long, and there's that spray that you can spray that eases because it's got a tiny bit of lidocaine in it. Helps. This is a foot antifungal, Lamisil. So put the powder all in your shoes, but it still dissolves. All of us are pretty familiar with calamine lotion. It's the pink stuff that you put on bug bites and stuff. And then these are insect repellents and Biofreeze. Biofreeze is my best friend. I got spray version of it. I've got patch version of it. I've got the gel version of it. So, but all of it's administered topically through the skin. And then, of course, Neosporin is an antibiotic ointment. These are all topical examples. And then this is going to walk us through those steps that we talked about. And like I said, make sure that you at least, if nothing else, go back and read over. Whenever we have to do anything, though, rectally, vaginally, always make sure that you have it's embarrassing for the patient. So make sure that you have drapes or, sheets to cover the patient. I know some doctors' offices, all they've got is those little paper things. If you got a bigger person, for the love of Jesus, give them a couple of them. Let them feel secure. Or, just because I've been and I'm a bigger girl, and you got to have a well-woman exam, and they give you this like little paper sheet, and it barely covers a boobie. So be think about that. Make sure you're thinking, hey, my patient feels as comfortable in the situation as they possibly can. And then this goes through the rest of the steps for administration. So on 2/26, the year 9 a.m., Dopalax, and Dopalax helps to stimulate, and it's a really mild laxative. 15 milligrams rectal suppository. Patient tolerated medication administration well. Patient verbalized understanding of a follow-up instruction. Denies pain or dizziness. And then they put their initials, which is good. Now, this is something that's new-ish. And when I say that, I mean, the last 30 years or so. We have the ability to administer medications transdermally. Now, that is really cool, and I'll explain why. So, Some people are really forgetful about taking their medications. Some people don't want the hassle. It's or their stomach gets really upset by taking, medications via oral, routes, and they don't want to be stuck all the time with injections and stuff. So the idea of a transdermal patch works wonderful because, and this is the one that I told you, this is one of the ones. If you have to place one on, wear gloves and try not to touch the actual medicine. A transdermal patch, what it does is it's a little bitty cloth-like patch, and the medication is condensed and it's formed into the inside of the patch. Now, they use this for birth control, hormones, anti-nausea drugs, pain relievers, cardiac drugs, blood pressure medications, you name it. Nowadays, smoking and ease sensation to help, with the withdrawals of smoking. So transdermal patches are a safe and effective way to deliver medication over a slow amount of time because it's designed in the patch not to just release all of it. It's a slow dissolving process. My dad was on a transdermal blood pressure medication, and so just went on his side of his hip, and it was just like he didn't even have to worry about taking a blood pressure pill or anything like that. Worked out really well. And I've seen a lot of women who are menopausal, who have hormonal patches and so forth. So this is not an uncommon thing nowadays. Please always wear gloves. It is something that if you're touching with your bare fingers, you do not want to have that medication on your skin and affect you, or it also to take away any of the medication that was meant for the patient. And here's an example. She's wearing a transdermal patch, and she has to put it up here on. She decided to put it here. And most of the time, the doctors and from pharmacies, from what I understand, they'll tell you can place it pretty much anywhere. You can even have it put someplace inconspicuous so that it's nobody else has to see, oh, she's got some kind of patch on. So it can, like I said, my dad wore his on his hip. I've seen people who place it on their lower back, some people who put it on their shoulder. So I've seen it in different areas. Now the next thing we're going to get into is we're going to start talking about what we call parental medication administration. This is write this down. This is any medication that's given outside the GI tract. And when we talk about these are the ones that we're talking about. We're going to be given by injection. Okay, like the intramuscular, subcutaneous, intradermal, and intravenous. These are all the ways that you can give parental medication. Actually, another way that's not on there is called the ET tube. And as a paramedic, once we had somebody intubated, I could just dump drugs down their tube. But that's more advanced. Parental medications are injected and delivered by the bloodstream. So that's why when we give these medications, we want to make sure that we have done all of our rights. We've gone through that. We've checked it 3 times because we are, even if it is, let's say, subcutaneous, which is one of the slower routes, right? It's still going to be entering into that patient's bloodstream within a 35, 45 minute time frame. So it's something you have to make sure that you have checked and you've thoroughly went through. Some parental medications, especially like steroid injections, pain medication injections, they may be given directly to target an area. So I know I've had steroid injections in my knees and in my shoulders, and those are usually a little painful, but they usually give immediate relief to the patient within, after administering. Medications that are usually direct target like that are done by doctors because there's precision, and it's not something that because of the pain level, it's something that we as MAs normally do. But we do administer lots of intermuscular and subcutaneous and even intradermal injections. And 1 second. Now we're going to start talking about the syringe. I'm going to put a couple of diagrams on teams that I'd like y'all to take a look at, okay? Syringes, we're going to learn the parts of them. The lumen is the bore of the hollow needle. The lumen size determines the gauge. And a lot of people get confused by gauges. Nowadays, we have a lot of people who gauge ears, different things like that. So, or they have body piercings. They're a little more familiar with how gauging works. So, if I say a 10 gauge, most people who are not medical would be like, oh, 10 small, right? Compared to a 22, right? Wrong. It's the opposite. A 10 gauge needle is massive compared to a tiny little wee thin little tiny 22 gauge. So when we're thinking about gauging, just remember it's opposite. As a MA, you're going to be dealing with 22, 21s. Those are maybe even a little smaller, but those are the common gauges. And emergency medicine, I used to deal with 18 and 16 gauges, at times 14. So that's because why? Let's think about a gauge and the lumen, the size, the opening. If I'm just giving a tiny bit of medication, I don't need a gigantic needle. But if I'm in a 911 emergency situation, I want that needle to be as open and wide and big as possible, because some patients I was having to squeeze fluids into their veins. So I needed that needle to be as big as possible. So that's usually why we look at the situation, we look at the patient, and we judge the gauge of the needle that we're going to need. You're not going to be coming at some, frail 98-year-old woman who's barely 100 pounds with a 18 gauge needle for some type of IM injection. You'd hit her bone. That'd be horrible. So like I said, I was trying to explain. And once y'all get into lab and you start picking up the needles, getting familiar with the equipment, like once it's in your hand and you can see, it really helps you be able to see. Usually this is a point where I would pass around the different size needles. I'd give you a 21 gauge compared to a 18 gauge. I used to keep a 16 with me to show you. And you'd be like, oh my God, there's a big difference. If you've ever went and given blood, they used probably an 18 gauge and that was a pretty big needle, but that's kind of like what we're talking about. And I have a sheet that I'm going to post that will help you remember this. The syringe parts, or the shaft, and then that of the needle, and that's actually the length is the shaft. The hilt, this is what connects the shaft to its hub. And then the hub connects the needle to the actual syringe. And this will all make sense when we see, the pictures of it. Now this, for the syringe, the barrel, this is the area that holds the liquid or the medication. And then the flange, that's like the little part that sticks out, and it prevents it from rolling around when you set it down and, rolling off the table. And then you have the plunger. The plunger, when it's pressed, is what expels the medication, but the plunger, when pulled, is what gathers or brings in the medication to the syringe. Am I with everybody? Have I lost anyone? We're doing good? Okay, so here's a picture, here's an example. So here's our lumen, our shaft of the needle, the hilt, the hub, see how it connects to the syringe? Now, like I was telling you yesterday, some of your needle syringe combos are already come attached. Most of them, though, you will pick an appropriate needle and attach it at the hub to the syringe, okay? Pre-filled medications, they are usually everything combined with the medication already inside, all right? The barrel, the flange, and then the plunger, how we pull up and administer. And I'm going to post these pictures, okay? Syringes come just like needles in a bunch of different sizes. The smallest size, you need to write this down. This is important. The smallest size syringe is a tuberculin syringe. And you're usually going to be able to spot a tuberculin syringe all the way across the room from someplace because it's usually color coded, or just the sheer tininess of the needle, of the syringe itself. And it's calibrated and measured in hundredths of a millimeter. And this is why yesterday when I was talking to you, knowing the syringe and making sure you have the right syringe for the job is vital. Because if a patient's given, let's say, you're supposed to be giving them tuberculin in 100th of a milliliter, and you end up using a regular, 3 cc syringe and give them the wrong, you could kill them, or you could seriously injure them. So this is why knowing your syringe types, making sure you've checked these things is vital. This here, these are talking about the different types of medication. They call this like a MedSaver syringe because it has a little cap that prevents this from being expelled before it's delivered. These are great because you can one-handed recap and then place this back on and set it inside your pocket to go into the room to deliver the medication. One of the things, if we were in lab together, you would hear me say repeatedly is that once you've drawn a medication in and you've checked it 3 times, you never set it down. It is on your person, your body, or on the tray you're holding at all times. And if for any reason you have to set that medication down and you walk away from it, no matter how long it is, if it is out of your sight and not on your person, when you come back to it, it's discarded and dumped and recorded, because you can never be 100% sure that it's exactly what you drew up. Something could have happened. It could have got switched out. Freaky things happen. So we are always keeping, once it's on, and because we usually draw our medicines up in the little workstation and then bring them into the patient's room. And especially with PD patients, we want to hide them because we don't want them seeing us coming in. These are the safety locks that I was telling you about yesterday. And once they're done, the barrel pulls up. And then the you can see the differences between the tuberculin syringes. There are different kinds, okay? Unless once you're able to get these in your hand and hold these, get a real grasp of it, it does make things easier. Now, the insulin syringe is one of the ones that I'm going to stress, and then I'm going to stress again, and then I'm probably going to bring it back up a few hundred other times. When you are working with a patient who is diabetic and you are administering insulin, you got to understand that insulin's a life-saving drug, okay? Giving them the right dose can save their life. Giving them the wrong dose can end their life. Plain and simple, okay? And there is only one syringe we will ever use to administer insulin, and that will be an insulin syringe. We will not use and never get into the habit of using insulin syringes for anything but insulin. And I know there are people out there who are going to do it. Don't be one of them. Because what you do builds muscle memory and builds a habit. And if you always are in the habit of never picking up an insulin syringe unless you're administering insulin, you're a lot less likely to make the mistakes. Insulin syringes are measured in units. All right, so it's completely different than other syringes. And this is marked. And the physician may order various types of units, amounts, and stuff for the patient depending on their blood sugar levels. Okay, so it's automatically, it didn't give us a picture of an insulin syringe. I'm actually going to pull that up. Please let me know if y'all can see. Can y'all see my screen?
Yes.
Yes.
Thank you. All right. So back to what we're looking at. If you notice with each one of these, there's something that almost every single one of them has in common. And what's that? There's some type of orange cap that's associated with them. Universally, we try to stick with that. Universally, it's very common that when you see an orange capped needle, you're thinking insulin. Okay. And I know in the field as a paramedic, that was the only thing that was this color were insulin syringes. And you can see, compared to, like in this person's hand, this is a very good example. You can see how small it is. And this one is very good because, and this is, like I said, this is done in units. And let's see if I can see I was trying to see if I could see the actual, yeah, it says right here, if you can, I don't know if you can see that, but it says units right there. But that's what I wanted y'all to see. I wanted y'all to be able to see that, and that how that it was, it usually should stand out and be very noticeable that it is an insulin syringe, okay? So that now it moves straight from that back to different other syringes. Now I know we're almost at 45 minutes, so I am going to stop here for the day, ending with insulin syringes, and I am going to, in Teams, I'm going to post the picture of the syringe with its parts. I'm going to send you pictures of different types of syringes. And then I'm also going to post a video specifically about insulin and insulin administration and give you your first look at this, because what we're gonna get into is subcutaneous. That'll be our first type of injection we're gonna learn about. All right. So now I'm gonna post a video about that. Okay. Does anybody have any questions?
Nope.
No? Y'all are all good. Okay. That's wonderful. All right. Well, I appreciate everybody being here. And if you haven't done your Survey Monkey yet, please make sure that you do so. And let me know if you have any questions. Remember, if you're an online lab student, you do need to be, and most of y'all are so great. I love reading y'all's lab responses that you leave to the comments. Some of them are so excellent. And make sure that you are leaving comments with that. And make sure that if you're not here for a lecture, that you leave a response to the lecture or whatever. So besides that, watch your due dates. You do have a project coming up. And if you have any questions, just holler at me. Bye, guys.
Bye. Have a great day.
Thank you.
Bye.